This session is free paper, optics, refraction, and contact lens. And our chairman is Dr. Usha Johri. She's sitting beside me. I am co-chair, Professor B.N.R. Subudhi. Convener, may I request Dr. Dharmendra Nath to come? Dr. Dharmendra. Co-convener Radharaman, Dr. Radharaman. Moderator Dr. Pooja Hingorani. Please do come. Ma, you want to speak something? Please. No problem.
Come. So, very good afternoon to all of you. I welcome you all to this very important session, optics, refraction and contact lens, which I think most of the ophthalmologists, neglect this topic.
Yeah.
I think my co-chairman will agree with me. And I would like all the presenters to stick to their time. And we start off with the first presenter. You'd like to speak something? We start off with the first presenter, Professor Avadesh Kohli, followed by Vishwa Panchal, Patsarthi. So all the next presenters, could be ready.
And if they can come to the front, it will be good.
Yeah.
Each presenter 5 minutes.
Okay, sir.
Yeah. Where are presenter? Please be seated.
Please be seated.
206.
Yeah. Yes. Yeah, he's already.
She is the first speaker. Now you can start. Yes.
Screen, please. Good afternoon. I'll be presenting on optical density and polarized light microscopy to confirm calcification of intraocular lens. No financial disclosures. So intraocular lens calcification actually refers to haziness or clouding within the substance of an IOL. It is rare but a serious complication, and most of us would have encountered this in our lifetime. It can lead to IOL exchange. Both types of IOLs, philic and phobic, they can calcify, and important risk factor is use of gas C3F8 or SF6 for post-keratoplasty or vitrectomy. So if we look at the types of calcification, it is primary when it is related to the intraocular lens, and secondary because of some other factor. So whenever we are in the literature also, the diagnosis has been based on microscopy and very high-end instruments like electron microscopy and X-ray spectroscopy. So in this, we actually studied the calcification in vivo using innovative use of optical density on a ImageJ software on the ultrasound UBM images, and also use of polarized light microscopy, which was available with us. So this case was a 77-year-old male. He presented with a visual acuity of 3/60 in the left eye, 4 years after he had undergone cataract surgery 10 years back. Right eye essentially was normal, but left eye, if you see, his vision was 3/60, and the intraocular lens, more so in the periphery, is opacified. And also earlier attempt to visually rehabilitate him by some other center, his yak capsulotomy was also done. When we did the UBM of this intraocular lens, on the left side is the UBM of the right eye, and at the yellow arrow you can see that even inside the IOL you see that there is hyperechoic shadowing, which is shown in the inset on the above pane. So we had earlier used this ImageJ on differential optical density of fluid on incapsular bag syndrome, which are clinically not very evident. So the optical density is a concept. Actually, it calculates the amount of light received by the sensor while passing through a particular medium. And even in ophthalmology, in other diseases also like retinal fluid and other conditions, this ImageJ software has been used, and it is a Java-based free-to-download software. So this is how the software interface looks like. First, you calibrate the from the sample image, and then you can upload your image. Like in this case, once you upload this image based on UBM or OCT, then you can easily calculate the optical density of whatever area you want to calculate. So in this case, we found there was a significant difference on the optical density, and this is a very, very objective method, more so in subtle cases. So coming back to our patient, the patient underwent anterior vitrectomy and IOL exchange because as said, there was a PC defect because of yak capsulotomy, and a sulcus placed 3-piece intraocular lens was placed, and his vision improved significantly to 6/18. Now we sent this IOL to our pathologist. She was also really not aware what to do with the sample, which happens with most of multi-specialty practices, where the ocular portion of the pathologist is actually, she also gets foxed. So when she did the microscopic examination, it could reveal these beautiful whitish deposits, which were identified as calcium crystals. And subsequently on a polarized microscopy, without any specific stain like von Cosa or other specific stains for calcium, these crystals, they resembled actually the calcium carbonate crystals which are seen on urine sediments. So polarized light could beautifully picturize these deposits which were on the surface of the IOL. So this report actually adds on to the existing literature of calcified IOL, wherein you can use a image based on UBM or OCT and apply it to ImageJ software, and even subtle changes in the optical clarity of the IOL can be made out. A word about IOL calcification, that when approaching a case, such case, we should actually make out whether it's primary, which is IOL related, or secondary, which could be patient related. And as an organization, we should ensure strict lens fabrication and packaging, and a national registry may be at AIOS level to report such issues. Thank you.
It's a really good presentation. At last, what is your conclusion?
Sir, the conclusion is that this innovative method can be used in cases where there is subtle changes in the IOL calcification, like the previous surgeon, he would have thought that it is because of the PCO and he yacked it, and such cases sometimes may lead to difficulties while doing a IOL exchange because now we don't have the intact capsules.
Is there any study which has been carried out as to which lens, because there are so many lenses available in the market, the incidence of this calcification is more with which lens?
Ma'am, earlier literature shows that when silicone lenses, they were very popular, so those lenses used to calcify rapidly, but now even where the certifications are not very clear, even other acrylic lenses, they are also being seen, but silicone was the most common.
Very good presentation.
Thank you.
Next speaker, Dr. Biswa Panchal. And after that, Dr. Parthasarathi Roy to get ready.
Good afternoon. I'm presenting a paper on comparison of time taken to read the stereo acuity plates between medical undergraduates with and without refractive error. The medical profession requires good stereo acuity while performing fine skilled near work. Suboptimal stereo acuity hinders the performance of such tasks. The study conducted by Biddle M. et al. Showed evidences of not only reduced but total absence of stereo acuity in practicing surgeons when tested for the same. So, assessment of stereo acuity among medical undergraduates is necessary. The Netherlands organization TNO plates are routinely used for assessment of stereopsis and suppression. In this study, medical undergraduate students have been assessed for the level of stereo acuity, and the duration taken to interpret the TNO plates by emmetropes and those with corrected ametropia was documented and analyzed. It was a cross-sectional observational study conducted in a government medical college among 400 medical undergraduate students from April 2021 to June 2022, after prior approval of the Institutional Human Research and Ethics Committee. Consenting participants were enrolled for the study. Students having any organic ocular morbidity and like corneal opacity or traumatic or developmental cataract or any retinal pathology were excluded from the study. After noting the demographic details, participants were inquired about any ophthalmic complaints, and history of spectacle or contact lens use was noted. Distant visual acuity and near vision for each participant was assessed with Snellen's illuminated chart and Roman's chart respectively. Cycloplegic refraction was done with those with subnormal vision, and which was followed by post-mydriatic testing. Best corrected visual acuity was documented followed by testing for stereopsis with the TNO random dot stereoacuity plates. The time taken to read plate 1 and plate 5 was recorded for each participant in seconds. The data was entered in Microsoft Excel 10 and analyzed using SPSS version 26, and unpaired t-test was applied. Out of 400 students assessed, 257 students had refractive error. It was observed that most of the emetropic students were having normal stereopsis, and of the 79 students who had abnormal stereopsis, 77 had refractive error. One student was diagnosed with anisometropic amblyopia, and 6 students were having abnormal stereopsis and they could not read plate 5. So 7 students were excluded from the study that was the analysis of data for the time taken that was done. We found that average time taken to read the gross stereopsis plate, the plate 1, was slightly more in those with emetropia than in emetropes. However, this difference was found to be not found to be statistically significant. Statistically significant difference was found in the time taken to interpret the fine stereopsis plate, that was plate 5, between those with corrected emetropia and the emetropes. Most researchers in the past have shown that uncorrected refractive error is a notable cause for decreased stereopsis. All kinds of refractive error lead to a visual blur, resulting in decreased binocular function with low sensory fusion. In this study, majority of students had good stereopsis, which was higher as compared to other studies, as 1/3 of our participants were emetropes, while in other studies, students with refractive error were enrolled. The analysis of time taken to read plate 1 and plate 5 of TNO chart and its comparison between the emetropes and ametropic candidates was done for the first time to the best of our knowledge. We observed that both emetropic and those with refractive error took approximately 30 seconds to interpret the gross stereopsis. However, those with corrected refractive error took almost a minute to read the fine stereopsis plate, while it takes around 35 minutes for emetropic candidates to read the same. We suggest that subjects with refractive error should be given at least 1 minute to read the TNO plates, and they should be motivated to focus and for a minute to not record false low stereopsis. The candidates with delayed response should be encouraged to view constantly and focus for a minute at least. And this information gathered will also help us to assess stereopsis in children, pediatric age group, and they tend to lose focus and they don't verbalize easily, so they should be given at least 1 minute before we reach a conclusion. Thank you.
Were most of your patients myopes?
Most had a compound myopic astigmatism, and then there was simple myopia.
So was there a difference between those with myopia and hypermetropia? Because you've just corrected their myopia, you said. Some of them must have been corrected prior.
Yes.
Some were already wearing glasses. Did you find a difference between those who were already wearing and those who had to adjust to new glasses?
No,
or
ma'am,
between
those
myopes
with,
and hypermetropes?
No, that was not. There was no difference. Those with.
Or have you checked it, or
yes,
there was no
10
difference?
students were they did not know of their subnormal vision, and they were correct. They were diagnosed with refractive error at the time of the study, and there was those who were excluded from due to abnormal stereopsis. They already had refractive error, and they were using glasses.
So how it is useful to the students?
So, it can give a perspective about the specialties in which they want to, in
Pursue.
future, which they want to perceive. Like the study that was conducted by Biddle and et al., it showed that most surgeons, they on using visual aids like the microscopes, they perform almost equally well in both this, equal in both.
Okay,
equal
thank you.
as those without refractive error.
Thank you, thank you. Thank you. So Dr. Parthasarath Rai, next speaker. Yes.
Good afternoon, everybody. I'll be presenting my innovation in novel study on timolol maleate 0.5% eye drop as a potential agent for presbyopia correction. I am Dr. Parthu Sahitri Rai, Associate Professor, Department of Ophthalmology, Calcutta National Medical College. I have no financial interest in this presentation. In recent times, there has been interest among researchers to develop pharmacological agents to treat presbyopia. However, success to this aim is not overwhelming. Only pilocarpine 1.25% eye drop has been approved by US FDA till date. But there is some inherent problem of pilocarpine eye drop used in presbyopia, like compromised distant vision and narrowing of visual field. We hypothesize timolol maleate 0.5% eye drop to have such properties that it would be able to treat presbyopia, at the same time overcome the side effects of pilocarpine. Intrinsic tone of the ciliary muscle is maintained by mutually opposite interaction between parasympathetic and sympathetic innervation. The parasympathetic innervation tends to contract the ciliary muscle and the sympathetic tends to relax. Therefore, blocking the sympathetic innervation by instilling beta blocker drug like timolol maleate 0.5% drop will increase the tonic accommodation and therefore may be helpful in the treatment of presbyopia. This mechanism spares pupillary muscles, thus do not have any effect on pupillary diameter and also avoid side effects of multi-drug combination drops which are currently under investigation. Moreover, by use of timolol maleate, distant vision is not blurred. So our aim is to determine and compare the near point of accommodation and amplitude of accommodation of the subjects before and after instillation of timolol maleate 0.5% eye drop. Methods we employed is after institutional ethics committee approval and for consent, we recruited 40 metropic subjects of ages between 35 and 45 years and randomly assigned them to binocular once only instillation of 1 drop of timolol maleate 0.5% eye drop, in intervention group 20 subjects, and in normal saline eye drop, which is control group, 20 subjects. For every subject, BCVA, IOP, near point of accommodation measured by Royal Air Force rule, and amplitude of accommodation calculated from NPA were noted prior to giving the drop and after drop half an hour interval for 10 hours. This is our result with near point of accommodation. The mean near point of accommodation is 24.95, which has reduced between 4 and 8 hours to about 19 millimeters. So 5 millimeter nearing of the near point of accommodation between 4 to 8 hours after installation of the drop. This tantamounts to about correction of 1.21 diopter of the amplitude of accommodation. Here you can see, soon after giving the drop, there is nearing of the near point of accommodation. It has started and there is stabilization between 4 to 8 hours, whereby it is reduced by about 5.79 millimeter. This is the mean value compared with the control. If we transform into amplitude of accommodation in the diopter value, then this is the result, and you can see the graph that it starts going up and we stabilize between 4 to 8 hours, by which time there was a correction of 1.21 diopter of presbyopia. So, near point of accommodation maintained a steady state between 4 to 8 hours of installation at points closer to eye by an average of 5.79 plus minus 2.87 centimeter. This tantamounts to presbyopia correction of plus 1.21 plus minus 0.42 diopter sustained for 4 hours between 4 and 8 hours after installation. There is no blurring of distant vision and no statistically significant lowering of IOP. So our conclusion is 1 drop of timolol maleate 0.5% eye drop instead binocularly can achieve correction of presbyopia to the extent of plus 1.21 diopter sustained for 4 hours, between 4 and 8 hours after installation of drop. Thank you.
How do you propose this can be escalated? I mean, how do you feel that this can be used in future? Because 4 to
Actually-
8 hours and just one
actually-
diopter.
Okay, ma'am. Actually, this is the first time in the world that the study has been taken. The timolol maleate 0.5% has been tried for presbyopia. This is number one. Number two, I have just instilled one drop binocularly once only. This is the result. Now, I am getting 1.21 diopter of correction between 4 to 8 hours. Now, the next aim, my next aim will be, it will increase the duration of action by just putting a top-up drop, say at the end of 5 years, 5 hours. Then it will maintain for another 4 hours. This is to be proved by study, but this is number one. And as it is now, for transient use, see, for sewing, household sewing, cooking, and reading this type of conference, for 4 hours you can use as it lies now. And next thing that we can add it up to pilocarpine. Then we can use this as a constant for long-term use.
Yes, thank you. No doubt it is be useful, but I would say that comparing the cost of the drug, side effects, and using this drug for only transient, so will it be any helpful to the patient for correcting for only a few hours of presbyopia? Otherwise,
Actually, we took in the exclusion criteria, we exclude the cases of diabetic with the other COPD, the heart block, the asthma patients, we excluded. So there is no safety issue, at least in this study.
correct.
So do you, feel that patients are already using timolol maleate for glaucoma, they will not develop presbyopia?
Actually, nobody bothered to investigate it.
Can you?
If you investigate it, maybe that somebody getting, and my hypothesis is based on, is a pharmacological basis. No? Pharmacological basis, the hypothesis is there.
Thank you very much.
Okay, thank you very
Okay,
much. So
okay.
we move on. Next speaker, Dr. Chinmay Sarkar.
Dipayan Sarkar.
So Dipayan Sarkar.
Dipayan Sarkar, followed by Dr. Jay Gopal.
Respected judges, delegates, and my dear friends, a very good morning to you all. The topic for my today's presentation is software-based binocular amblyopia therapy, a newer advent in treatment of amblyopia. Is it a fact or a fancy? What is amblyopia? Amblyopia is unilateral or rarely bilateral decrease in the best corrected visual acuity caused by vision deprivation or abnormal binocular interaction for which there is no identifiable pathology of the eye or the visual pathway. It occurs when there is a breakdown in how the brain and the eye work together and the brain can't recognize the images from the eye. Amblyopia starts in the childhood, and it is one of the most common cause of vision loss in children. The types of amblyopia basically being stimulus deprivation, meridional, strabismic, and mixed. What is the prevalence of amblyopia? The global value stands at 1.75%. The European office reports it at 3.67%. The African office reports it at 0.51%. The Indian prevalence values in 1997 study shows 1.10. In 2002 study shows 4.4. And 2015 study 6.6%. The pathophysiology of amblyopia basically revolves around the visual deprivation, which can be monocular, binocular, it can be light deprivation or abnormal binocular interaction. It is basically the concept of amblyopia basically revolves around active cortical inhibition. This is a developmental defect of spatial visual processing occurring in the visual pathway. There is poor transmission from the fovea optic nerve to the striate cortex of the affected eye. Lateral geniculate body and the striate cortex also develop abnormally. The ganglion cells in the foveal areas are affected. There is shrinkage of the LGB nucleus and the striatal cortical fibers in the amblyopic eye. Diminution of binocularly driven cells in the LGB and the striate cortex. The diagnosis of amblyopia is mainly through the clinical history, binocular red reflex test, binocularity, stereo acuity testing, evaluation of the visual acuity fixation pattern, binocular alignment, ocular motility, pupillary examination, detailed fundus examination, cycloplegic retinoscopy refraction, neutral density filters, and looking for the crowding phenomenon. The present standard treatment modalities are the principles are to eliminate any obstacle to the vision, like the cataract, ptotic eyelid, correct refractive errors, force use of the poorer eye by limiting use of the better eye. The other treatment modalities being cycloplegic refractive correction, surgery to remove the stimulus deprivation, occlusion therapy, penalization, cortical stimulant medications like citicoline, play optics, CAMP stimulator. Occlusion therapy is the gold standard for treatment. The principle is to enable the better eye to take fixation and to remove the inhibitory stimulus, thus helping in the cortical stimulation and development. It can be done up to 12 years of age, but it is best effective till 10 years of age.
Level 4.
Patching duration is advised full day occlusion, but compliance, if the child is not compliant, at least 4 hours of daily therapy is done. So what after 12 years? Many adults are late diagnosed for refractive errors when they have already developed amblyopia and have crossed the age of visual plasticity. These adults were sometimes given occlusion therapy trial and sometimes counseled for the disease and explain poor visual prognosis. Here comes the software-based binocular vision therapy. For this study, we have used the QRC vision therapy software. This is an artificial intelligence-based vision therapy software to treat amblyopia. In QRC, there is a combined monocular and binocular exercises along with Gabor patch. The science behind it is random dot stereogram modules, dioptic principle, crowding phenomenon, anti-suppression technology, combination of monocular binocular exercises, individualized and customized contrast threshold, and Gabor patch exercises. The aims and objective of the study are to evaluate the visual outcome of software-based binocular amblyopia therapy in amblyops pre and post therapy. Importance of the study being, over the years there have been various treatment modalities that have been published, but none has been found to be very effective clinically. The binocular amblyopia therapy is another new therapy treatment modality on this horizon. So, is it a fact, fancy, or a gimmick? Methodology, area of study is Nanika Eye Care, Bardhaman. We had a sample size of 42 subjects of age group 12 to 45 years enrolled in the study. 4 were excluded due to poor compliance to therapy, which is less than 50% of therapy days. Inclusion criteria, patient diagnosed with amblyopia and undergoing QRC therapy, patients giving consent for the study. Exclusion were patients with recent ocular diseases, treatment within last 1 month, patients with any ocular pathology other than amblyopia, patients not giving consent for the study. The method followed was preliminary examination,
Doctor,
visual
can you
acuity on
conclude now?
Snell's.
Please conclude. The time is
Yes.
over.
The slit lamp examination, statistical analysis was performed. Results: male were 64%, females 35.7%. This was the age distribution in the study. This was the pre-treatment visual acuity. The most of the subjects were between 624 to 660. Visual improvement of 1 month, within 1 month of therapy, was seen in 2 Snell's line improvement, at least 2 Snell's line improvement was seen in 78.9%, while none of the subjects showed no improvement. Subjects attained 6/6 vision in 1 month of therapy were 4, 2 months of therapy were 14, 3 months were 8, more than 3 months continued therapy was 14. All study subjects of varied age groups showed some improvement in visual acuity in 1 month of therapy. 78.9% showed.
Dr. Sarkar, conclude.
Binocular amblyopia therapy shows promising and encouraging results with good visual recovery from first month of treatment itself. Only few individuals complained of initial headache, which resolved over the counter analgesics. Thank you.
excellent one, but we could not complete your talk completely. We missed some of things. So what do you suggest? Is it useful to the
Yeah,
people?
I have found it in my study. I have found it to be an useful tool because in all the patients I have used, I have found some visual recovery in at least 1 month of therapy. Most of the patients showed two sentence line of recovery within 1 month of therapy, while some showed 1 sentence line and few showed more than 2 sentence line recovery.
Yeah, what is the recommended duration of therapy and the cost of therapy?
Madam, the cost of therapy is as per the company. They provide 3 modules for the therapy. For the 1 month therapy, they are charging 2,800. This is from the hospital they charge. The hospital can charge whatever they want from the patient. For 2 months, for 3 months, I think it is 5,000. For 6 months, it is 9,000. And the therapy, duration of therapy is generally I start with a single month of therapy and then I proceed till the patient attains 6/6 vision.
So what is the frequency and is there any dwindling after the therapy stops? Like
No, madam, I haven't followed up all the patient. This is a 3 months of study. The patients are still under my follow-up. I haven't seen any patient reducing their visual acuity or losing the gained visual recovery. But I should do a longer follow-up to come up with definite results.
thank
Oh,
you.
thank you.
Thank you.
Next speaker, Dr. Jai Gopal Agrawal.
Good afternoon to everybody. My paper is for excellent refractive outcome. Is artificial intelligence based IOS calculation emerging new trend over the current practice? There is no financial interest. Now the purpose of the study is to compare the accuracy of widely used IOL power calculation formulas including artificial intelligence based formulas. There are 2 groups as shown in the slides. First is the artificial intelligence group formula and another is regression formula. Pre-operative investigation is the retrospective series and IL master 700 readings are taken and the patient is distributed in groups in terms of their axial length. Group 1 is more than 24.5 millimeter, and group 2 is 21.5 and 24.5, and group 3 is less than 21.5, that is hypermetropes. After 1 month, we get again taken the best corrected visual acuity, post operative actual visual dioptric power, and the number of dioptric errors. These are the inclusion criteria of my study. These are the exclusion criteria. Now, this is the data what I have collected. It is only part of it. It is the vast data. Now, it is a calculation. Refractive mean numerical errors and the mean absolute errors of IOL formulas at different axial length group are calculated and compared. Refractive error absolute values in percentage of each formula is calculated at 0.25, 0.51 and 2 diopters. The mean absolute error is used as the indicator of IOL formula prediction accuracy. A small standard deviation in MAE shows that the accuracy of the prediction is very good. The centroid residual astigmatism prediction errors are calculated for each method where we opt for the toric IOLs. In this case, it is 26 cases. Here is a demographic and pre-operative biometric parameters of the patients. This is the mean numerical error which I have collected, and it is shown in the graphs. As shown in the artificial intelligence based formula is the least mean numerical error. The mean absolute error also, that is artificial intelligence based formula, is better than other formulas. Now sensitivity of the formula prediction at 0.5, 0.25, 0.5 and 1 and 2. Here again, the artificial intelligence formula, especially Keynes, LEDA Super and Hill RBF, gives the minimal post-operative error in more than I within 0.5 diopters. This is the same thing shown in the tabulated form. The mean absolute error is smallest in the LEDA Super and the Keynes formula, followed by Hill RBF and other formulas. LEDA Super and Keynes formulas predicts more eyes within 0.5 diopters of spherical equivalence. For toric IOL, you will use artificial intelligence based formula for spherical part and the Barrett toric calculator for the cylinder part. So it gives the very accurate result. For the post LASIK calculation, no artificial intelligence based formulas till now. This is the centroid error in which I have shown in the slide the artificial intelligence formula along with the Barrett-Torrey calculator for the cylindrical part gives the maximum good result both with the rule and against the rule astigmatism. And here again, the artificial intelligence formula along with the Barrett-Torrey calculator gives the excellent results. For extreme eye, again for the long eye, MAE is smallest in the canes, followed by LEDA, super and heels, then followed by others. And for short eyes, again, the cane is predicted the more eyes within spherical equivalent is 0.5 diopters. This is a short eye, that is a hypermetropic eye I have done in 29 cases, in which it is shown that the artificial intelligence, especially the canes, gives the excellent results both with in the term of mean absolute error, numerical errors, and sensitive with up to the 0.5 diopters. And for the long eye also, we have get the same results. This is the Chang study. Again, here it shows that the Keynes formula is better than the others. To conclude, Keynes and artificial intelligence formula is a single answer for all IOL query, all calculation queries. The artificial intelligence formula is totally data-driven, artificial intelligence-based pattern recognition without estimating the expected lens position. And it is continuous evolving, thus coming to more and more accurate or accuracy more than 90%. Keynes and artificial intelligence formulas being the game changer in the biometry. Though the Barrett calculator is used very commonly, here the calculation of expected lens position is inbuilt and very accurate. It is important to use newer formula also, especially for extreme eyes, long eyes and short eyes, Keynes, Hill RBF and LEDA Super. For toric IOL calculator, I have found that online Barrett-Torrey calculator is a good choice. Thank you for your kind attention.
Excellent presentation, sir. Thank you very much.
Thank you.
Existing biometers are with us. Can we load this AI formula into that, this software?
Yeah, yes.
This can be added to the existing biometers?
Yes, yes. It can be calculated. It is also available in the online, and you can calculate it. It is very easy.
Okay. Thank you. Our next speaker is Dr. Pavitra Patel.
Good afternoon. First slide. Good afternoon, everyone. My presentation for today is comparing myopia control, defocus incorporated multiple segments, which is known as DIMS, versus atropine versus a combined approach. So as we all know, the prevalence of myopia is increasing year after year, and it is predicted that the prevalence of myopia will increase to up to 48% in the year 2050. There are various methods for slowing down the myopia progression, and the most commonly used is the low-dose atropine eye drop 0.01%, which acts on the sclera and inhibits the glycosaminoglycan production and therefore the eye growth. And the second and the recent one is the use of dim spectacles. It works on the principle of peripheral myopic defocus and simultaneous vision. It is a dual focus spectacle lens. There is a clear zone of 9 millimeters which corrects the distance refractive error, and there is an annulus in the mid peripheral area which comprises of several hundred circular segments in honeycomb pattern with a relative positive power of plus 3.5 diopters. So the aim of the study was to evaluate the efficacy of DIMS versus a low dose atropine versus a combined approach for myopia control. So this study was a non-randomized prospective controlled observational study which included 150 children in the age group of 8 to 18 years. Now all those children who had a myopia with a spherical equivalent refraction of between minus 0.5 to minus 4 diopters, astigmatism of less than 2.5, an isometropy of less than 1.25 diopters, and who were compliant with the therapy were all included in the study. And subjects who had undergone any previous myopia control therapy in the past or had a progression of less than 0.5 diopters SER in either eyes or had other eye diseases or suspected genetic syndromes were all excluded from the study. So all the children underwent a thorough eye examination, which included the measurement of BCVA and spherical equivalent. All the patients underwent a slit lamp examination, dilated fundoscopy, and axial length measurement using an optical biometer. Now, these children were divided into 4 groups. Group 1 was a low-dose atropine group, where 1 drop of low-dose atropine was instilled in each eye every night before sleeping. Group 2 were the patients who opted for DIMS glasses, and these patients were instructed to wear the glasses throughout the day. Group 3 was a combined group of DIMS glasses and atropine, which was used at night time. And group 4 were the patients who opted for or who continued wearing the routine spectacles and without using any therapy. Now, parents were free to choose their preferred option or to continue with single vision glasses or the routine glasses, and follow-ups were done at 6, 12 and 24 months after initiating the therapy. Now, these were the results. So, age distribution among the 3 groups, there was no statistically age difference between the 4 groups. When we saw the baseline spherical equivalent refraction, coincidentally, again, there was no difference, statistical difference between the 4 groups. And similar result was noted also in the axial length measurement at the baseline for the 4 groups. Now, there were 2 primary variables which we studied in our study. The first one was the change in the SER, or the spherical equivalent refraction measurement, which at 6 months interval for all the 4 groups didn't show much variation among the 4 groups, but at the end of 1 year and at the end of 2 years, obviously there was an increase in SCR in all the 4 groups, but the maximum increase in the SCR was, as seen in the graph, was seen in the control group who continued wearing the routine glasses, and it was almost about 1.5 diopter increase at the end of 2 years. And the minimal was seen in the group where the patients chose a combined therapy. Now, similar findings were also noted in change in axial length measurement. At 6 months, there was not much significant difference among the 4 groups, but at the end of 2 years, the maximum increase in the axial length was seen in the control group, followed by the individual use of atropine and DIMS, followed by the minimal increase was seen in the combined group. So, to conclude, individually, low-dose atropine and DIMS glasses have similar efficacy, which helps in controlling myopia progression by around 50% in our study and also according to various literatures. However, combined therapy of atropine and DIMS has the best efficacy in controlling myopia progression, which was around 65 to 70% in our study. So, the limitations, obviously, the therapy becomes slightly expensive, and the use of AI-based tool to predict myopia progression was not used in our study. Now, how do we translate this into our clinics? If we use an AI-based tool, which is recently launched, this helps in better understanding of the myopia progression, and it gives you this kind of graphical representation, which helps in convincing the parents better for which myopia control therapy to choose. Thank you.
My main concern is the randomization was not there here, and secondly, the choice is dependent to a great extent. A parent will never choose something, will not, if they can afford it, they'll take it.
Correct.
So the thing is that if they are more aware and they are better off financially, then the response and the follow-up and the confounding factors are very different in those groups. So you cannot really compare them so
But we couldn't randomize this study because of the same issue. The affordability is the main issue. So, but in a
These are the
non-randomized.
parents who are more aware and more motivated.
Anyways, all the children who were included in our study, all the parents were equally counseled about the
That
different
was another
therapies.
thing. Did you have equal counseling as in one video which was constantly played, or there is a tendency to group, like, oh, I have less in this group, so
No, not
or
ever.
some
It
days
was only
the
me.
counselling-
It was a one single person who counseled all the parents, and then the
even
parents.
the counseling should have a
Particular,
format.
yes, absolutely. There was
Those 8 points or 10 points,
Correct,
then
correct.
it becomes replicable.
Correct,
So
correct.
if you are just saying ki I'm the same person, but the format of
Yeah.
counseling also should be exactly the same.
It was same for all the patients.
What the range of myopia you suggested this?
0.5 to, in my study I included less than 4 diopters because we wanted to exclude the syndromic myopia and all those patients, which can affect the outcome of the study.
So higher errors you have included in the study?
Sorry?
Higher power.
More than -6.
More than -6. More
Less
than
than
4.
4 were included, more than 4 were not included.
Not included.
Not
she's
included.
telling. Not included.
Yeah.
she's telling.
Sometimes I think parent-to-parent counseling also helps a lot, especially with,
Yeah.
with the long-term results.
Counseling is a major thing in this study because it
Yeah,
was a non-randomized study.
Exactly.
Yes.
Counselor is one part,
Yes.
but one parent talking to another parent,
Correct.
that I think is a better way of doing a counseling.
Okay.
So what the cost factor you said?
Cost for the DIMS glasses was around 16 to 17,000.
You use
The
a
glasses.
single brand or a different brand?
Sorry, same brand.
Same brand.
Yes, Hoya. We used Hoya brand.
I think if once, this gains a popularity, the cost will come down. Isn't
Yes,
it? It's
maybe.
a demand and supply.
Yes. True. Thank you.
Thank you very much. Next, we move on to Dr. Krutika.
After Krutika, I think we have Shriya Hinje, Swati Bhattacharya, and Neetu. All are there.
Good afternoon, everybody. My name is Dr. Krutika, and today I'll be presenting my paper on visual rehabilitation in keratoconus. So keratoconus is an asymmetric, bilateral, progressive non-inflammatory ectatic disorder of cornea, which results in high irregular astigmatism, ultimately leading to visual reduction. The conservative approach available to improve vision in keratoconic patients are either spectacles or contact lenses. Initially, what we can do with these patients are, we can try with spectacles and we can try with soft contact lenses, soft or soft toric contact lenses. Whereas in advanced cases of keratoconus, a wide array of RGP lenses, that is specialty contact lens based on diameter, such as corneal, semiscleral or scleral lenses are available. So the aim of our study was to evaluate visual improvement with specialty contact lenses in patients of keratoconus status post corneal cross-linking. This was a retrospective study held at Center for Sight Eye Institute, wherein a data of 57 keratoconus subjects, that is 96 eyes, status post cross-linking, who underwent RGP contact lens trial and were prescribed the same. And the record was collected from 2017 to 2021. The data collected from these patients were BCVA was recorded by Snellen's chart both with glasses and RGP contact lens. Also contrast sensitivity was assessed. So the inclusion criteria in the study was data of keratoconus patients status post cross-linking who were prescribed a specialty contact lens irrespective of age, sex or any pre-existing morbidity. And the exclusion criteria includes those of patients with keratoconus who were satisfied with unaided vision in both eyes and those with additional eye diseases which would affect their vision. And the conditions like corneal dystrophy or corneal degeneration were also excluded from the study. The results are as tabulated below. So as we can see from this table, majority of the patients, that is around 29.8%, were in the range of 21 to 25 years, and majority of the patient, that was around 75.4%, were male. So we can see male preponderance from this table. And this table, which shows type of RGP contact lens, that is scleral or corneal RGP, number of patients included here was 63%, that is 60.4% of eyes, and corneal RGP was 36%, that is 39% of eyes. And in this table, when we found the BCVA, which was converted to logMAR value for glasses, for scleral RGP, and for the corneal RGP lenses, what we could analyze post after framing this table was there was a great statistical significance seen after giving contact lenses, either scleral or corneal, but there was no statistical significance between the two, that is the scleral or corneal. There was definitely significance between glasses and the contact lens. So RGP contact lens provides a tear film, a tear layer between the irregular corneal surface and the contact lens, thus providing excellent visual outcome for patients with keratoconus and improve patients' quality of life. Significantly, in our study, significantly better visual acuity was achieved with specialty contact lens, that is RGP contact lens, when compared with spectacles in patients with keratoconus post cross-linking, and there was no significant difference in BCVA between scleral and corneal RGP, as was observed in a similar study by Levy et al. So I conclude my paper saying that specialty contact lens proved to be a boon for patients with advanced keratoconus, poor visual prognosis, and unsatisfactory visual outcome with glasses. And the study reinstates the gratifying outcomes with specialty contact lens in terms of quantity and quality of vision in keratoconus eyes. Of the two contact lenses that were prescribed, scleral contact lens were found to be better rewarding and comfortable. Thank you.
weren't they also more expensive?
Yes, ma'am.
Stereo is very expensive.
Clear contact lens were expensive.
Thank you.
Thank you. Thank you, sir.
Patterns for presbyopic correction among ophthalmic surgeons while operating. So microsurgeries like ophthalmic surgery require an impeccable visual acuity, of which stereopsis forms an important component. Stereopsis is found to directly affect generic skills and intraoperative dexterity, and hence the surgical outcome. Presbyopia is known to adversely affect stereopsis, and therefore the surgical outcome also gets affected. So we decided to study the preference patterns for presbyopic correction among ophthalmic surgeons while operating. The objectives were to study the type of presbyopic correction used while operating and for checking patient records. We did a questionnaire-based cross-sectional study among 100 ophthalmic surgeons for a duration of 2 months, and information regarding age and gender, subspecialty, refractive error, duration of presbyopic correction usage, operative hours per week, refractive correction while operating, method to perform timeout, and stereopsis patterns were obtained. In the results, we found that majority of the surgeons belonged to the age group of 45 to 55 years, 45% were females and 55% were males. Among the subspecialty distribution, cataract surgeons and general ophthalmologists formed the major chunk. Presbyopia was the most prevalent refractive error, followed by presbyopia with simple myopic astigmatism and presbyopia with simple hypermetropia. Majority of the surgeons were using presbyopic correction for a duration of less than 5 years, and majority were high volume surgeons operating for about 5 to 15 hours per week. For presbyopic correction while operating, 61% preferred non-spectacle methods and 39% preferred spectacles. Among the non-spectacle users, 27 surgeons preferred to use eyepiece diopteric adjustment, and 33 surgeons did not use any correction while operating. Among the spectacle users, 32 surgeons used progressive glasses and 7 used monofocal glasses. For timeout, 54 surgeons used spectacles, 23 relied on OT staff, 5 used brick screen EMR, 16 did not require any correction to read, and one surgeon used magnifying glass as seen in this video. We also found that one surgeon does not perform timeout because of low surgical volume. For stereopsis patterns, 55% surgeons had never checked stereopsis, and among the 45% who had actually checked stereopsis, 51% suggested to have better stereopsis with microscope adjustment. On studying the stereopsis patterns in different refractive errors, there existed a statistically significant difference. So, coming to the discussion, over 50% of the cataract surgical load in the country is performed by the surgeons in presbyopic age group, and hence it is necessary to have a perfect refractive correction to gain high level of stereopsis and good surgical outcome. In a study conducted by Tuna et al., they concluded that presbyopia significantly diminishes stereo vision and hence influences the surgical outcome, and that surgeons with presbyopia greater than 1.25 diopters must always perform surgeries with proper correction. Similarly, in our study, we found that 60% of the surgeons had presbyopia of more than equal to 1.5 diopters, and 67% surgeons were using some form of refractive correction for presbyopia. Garnham and Sloper concluded that there is mild decline in stereo acuity with age, which is more significant above the age of 55 years, hence periodic testing is necessary. In our study, only 45% surgeons had checked stereopsis, among which 5% reported absence of stereo acuity, and only 27 surgeons had done so in last year. We also found that 40% surgeons preferred non-spectacle methods, which can be attributed to the low symmetrical refractive error. 60% suggested to have better stereopsis with microscope, and 50% were using presbyopic glasses for less than 5 years and hence were considered to be inexperienced. So to conclude, majority of the surgeons suggested to have better stereopsis with eyepiece diopteric adjustment, but practically only 1/3 preferred to use eyepiece diopteric adjustment, 1/3 did not use any correction to operate, and 1/3 used spectacles. For surgical timeout, majority of the surgeons preferred to use spectacles. 55% surgeons had never checked stereopsis. This highlights the importance to increase awareness regarding periodic testing of stereopsis by the ophthalmic surgeons, for which we would like to suggest a device to check stereopsis intraoperatively and a scoring system for grading stereopsis in near future. These are my references. Thank you.
You didn't test stereopsis in any of them?
No, ma'am. It was only a questionnaire-based study. We did not do any objective testing. Thank you.
What did you recommend now? Whether they have to go undergo stereopsis test before doing surgeries?
Yes,
All
sir.
surgeons you recommend to go for stereopsis test.
Yes, sir. Periodic testing is necessary. That is okay.
Thank you. Dr. Swati Bhattacharya next.
Good afternoon, everyone, respected dignitaries on the dais. My topic for today's presentation is effect of pupillary dilatation on biometric measurement using manual and optical biometry methods. No financial interest. Ocular biometry is the measurement of the anatomical dimensions of the eye, which include corneal curvature, axial length, white-to-white thickness, anterior chamber depth, lens thickness. In this presentation, we have taken K1, K2 keratometry and axial length as the parameters under study. The axial length is defined as the distance from the anterior surface of the cornea to the retinal pigment epithelium and can be measured using ultrasound biometry or optical biometry. Ultrasound biometry can be further divided into contact or immersion type. Accurately measuring the axial length is very crucial because 1 mm error can change the IOL power by nearly 2.5 times. Keratometry is the measurement of the power of the cornea, which is based on the corneal curvature and is expressed in diopters, can be measured via manual or automated methods. The purpose of our study is we want to understand the role of pupillary dilatation and if it will alter the K1, K2 and axial length by using these instruments, because it plays a role in predicting the accurate IOL power and post-operative refractive status of the eye. Here is one study which has been performed previously, effect of pupil dilatation on biometric parameters using Lenstar 900, and they have found that the first keratometry value did differ before and after dilatation. Another study was conducted previously, the effect of pupil dilatation on biometric measurements and IOL power calculation in school children, and they have found multiple parameters to differ before and after dilatation, such as axial length, anterior chamber depth, and they have also mentioned that IOL power changes exceed 0.5 diopters before and after dilatation. Material and methods, we have taken patients visiting MNJ Eye Institute with complaint of diminution of vision or routine eye checkup. The inclusion criteria were patients in the age group of 14 to 70 years of age visiting the hospital. The exclusion criteria was patients with any known case of glaucoma, previous eye surgery, any corneal pathology, or a known case of drug allergy to tropicamide phenylephrine eye drops. It was a cross-sectional interventional study with 150 subjects, that is 300 eyes, and the duration was 2 years. These are the instruments which we have used in the study. The Appasamy keratometer, Zeiss IOLmaster 500, Biomedics EcoRoll Pro 2, and the drug used was tropicamide phenylephrine eye drop. The results via manual keratometry I have shown via 3 graphs. The pre and post values have been shown of K1, K2 and the axial length, and we have found that K1 and K2 measurements, it shows a significant difference before and after dilatation. However, the same could not be said for axial length. Via the optical method, we have found that the K1 and K2 value, again they are having a significant difference before and after dilatation, but axial length did not differ when we use these instruments. So I would like to conclude by saying that there is a statistically significant difference in the flat and steep keratometry values before and after dilatation via the manual and optical devices. However, axial length did not seem to be affected by pupillary dilatation via these methods. Also, I would like to comment that when we use these 3 instruments, there was no significant difference amongst in the values calculated via them, and I have shown them in the graph. The limitation of my study was firstly the age group. We excluded patients less than 14 and above 70 years. And secondly, another study has to be performed to evidently conclude if the biometric parameter should be taken before or after dilatation whenever we call a patient to the OPD for IL calculation. Third, we have chosen only patients who have no other significant ocular disorder, which is not the case in real life scenario. These are my references. Thank you.
This just solves one problem in the clinic, which is should we check the IOL or the biometry when the patient is still dilated, or we should call him another time, or when he's undilated. But technically and in real life, I think a difference between a photopic and a scotopic pupil, the size would have been more relevant for the patient, whether the IOL power changes when a pupil is scotopic versus photopic. If that can be done, it would be more relevant for the patient.
Okay.
And it also depends on the degree of dilatation, isn't it?
Yes, ma'am.
How many millimeters you are dilating, whether it's fully dilated or partially dilated.
We had included
that will give
fully
you the-
dilated patients here, and any patient with less dilatation we had excluded.
And as she rightly mentioned, the night vision, night vision, the pupil is not fully dilated, isn't it?
Yes,
It's only bit dilated. And daytime, 12 o'clock, the pupil is very much constricted.
Yes,
Morning, there's a diurnal variation of the size of the pupil.
And illumination in the clinic also.
Yeah. Thank you.
Thank you, ma'am.
Thank you. Dr. Neetu Thankam. Last speaker. Dr. Neetu, are you there? She's upset? Okay. So I think this session is over. Thank you very much. I request all the speakers to come to the dais to take the photograph.